Good afternoon. Thank you so much for joining us today. We're so happy to be able to present this webinar to you today. My name is Tamara Bingham-Noyes. I'm the Director of Business Development at Center for Change. I've been at the center almost 14 years. It'll be 14 years in August, and I love it here, and I'm so happy to be able to be part of this process and providing education to those in the field. So thanks again for joining us today. I'll introduce Sam in just a minute. Sam is on with us as well. Sam Lample. First, we're going to do a few housekeeping items just to get everybody up to speed. Then I'll talk a little bit about Sam, and then we'll turn it over to Sam and let him run with it. First of all, a copy of the PowerPoint is in the handouts section of the toolbar. So if you click on that handouts section, you'll see that there's a copy of the PowerPoint there. You're more than welcome to download that for future use if you'd like to. A copy of the post test is also in that same section, in the handouts section. This is for reference only. In order to obtain CE credit, continuing education credit, you must take the online post test, and I'll talk more about that in just a minute. You are welcome to submit questions in the questions section of the toolbar. We'll try to get to a few questions at the end of the webinar, so feel free to ask questions throughout, and then we'll come back at the end and address some of those questions as we're finishing up. When the webinar ends, please fill out the evaluation that pops up. It will automatically pop up on your computer screen. If you take just 30 seconds to fill out that evaluation, that would be really helpful for us. That's a continuing education requirement for us. It's completely anonymous, so please feel free to be candid in your feedback there. We then tabulate those results and send those to the CE entities. So if you would take just a minute to complete that at the end, that would be great. And then about an hour after the webinar ends, you will receive a separate email from GoToWebinar with the link to take the online post test. It will look similar to the email that you got when you got a confirmation when you registered for the webinar. So again, it will come about an hour after the webinar ends. It will be from GoToWebinar, and there'll be a direct link in there that you can click on to take the online test. Once you pass the test online, then the certificate is automatically downloaded to your computer. If you don't see it on your screen, check your downloads file. Sometimes it hides in there. Okay, we're going to get going with Sam Lample. Sam's a licensed professional counselor. He's the owner and executive director of Thrive Therapy. Sam has been treating individuals with eating disorders and OCD for more than 18 years. He's also a really great human. Sam spoke at the Center for Change conference a couple of years ago. He really captivated our audience. He's very wise and knowledgeable, and his expertise is incredible, but he's also a compassionate, kind, humorous person and just a delightful presenter. So I'm so excited to have Sam with us today. I'm going to turn it over to Sam. So all right, Sam, here we go. Let me send this over to you. Coming your way.
All right. How are we doing so far?
Doing okay. You just need to get it in presentation mode, I think, so that it takes up the whole screen, because I see your other slides down the left-hand side.
Presentation mode.
So just click play, I think, at the top.
Oh, my bad.
That's okay, no worries. There it is. Okay, you're all set. I'm going to turn off my camera and my mic, but if you need me, I'm here, and otherwise we'll pop in when you're finishing up at the end. I'm turning it over to Sam. Here you go.
Great. Thanks, Tamara. Thanks, Center for Change, for having me. Thanks for all the kind words. It's been a while since I've done a webinar, although I speak a lot. But today is one of those days where I'm actually experiencing a little anxiety again. Normally, that's not the case for me, but what I tell myself in these situations, using my active fusion skills, is that my anxiety is generally a precursor to a really good conversation, a good presentation. This issue of adoption kind of fell in my lap recently, and although I've been treating individuals with eating disorders who have been adopted for years, there was some things that happened in the past 12 months for me that really opened my eyes to this conversation and this culture and this population. And that's really the way I would encourage everybody to view, or at least I should say it differently. That's the way I am viewing the issue of adoption in people's lives is that it is a cultural thing. And I very much did not understand that until recently. My presentation has an odd title, but you don't look adopted. And that actually comes from a particular real life situation in which an individual I worked with was adopted by a set of parents who were not supposed to be able to have biological children, and then about 9 months to a year afterwards had a biological child. And oftentimes individuals would say, I think in an attempt to make the adopted child feel better, oh, but you don't look like an adopted kid. And of course, what that did was the exact opposite, which was to single that child out and reinforce that everyone knew that they were different, even though they were trying to give them a message that suggested otherwise. This is perhaps the main point for me before I move on to the next slide. If anyone has ever heard me speak before, you know that as far as dialectical behavior therapy is concerned, I'm a huge believer in validating versus invalidating environments. And what I've come to understand is that a lot of my own language around and with adoptees was meant to be validating, and the reality was it was the opposite. I remember a few years ago, I was working with a particular adult adoptee, knowing that she was adopted and she had an eating disorder, and she was doing relatively well after 6 months. And, I started to have this preemptive conversation with her about step down. And, I was communicating to her that she was doing so well that I probably would not need to be in her life very much longer. And I got such a strong emotional response from that really did not make much sense to me. But over time, what I've come to understand is this. My comment and feedback to her, although it was warranted about her improvement with recovery behaviors and decrease with eating disorder behaviors, was valid. But she received that as a performance orientation message. In other words, that she was on stage for me and she was doing a really good job like she had always tried to do for the other adults in her life. And she also received the message about transition and discharge as a secondary rejection. And that, in other words, that although she was improving, she wasn't improving enough. And therefore, she was not good enough to stay in my life. So obviously that resulted in a more therapeutic relationship than I was expecting at the time. But I think it's a great example of how often the messages can get confused. And the last couple slides are going to reflect that. Let's move on a little bit here. So my learning objectives: increase awareness of adoption dynamics to identify eating disorder functionality in adoptees, common mental health found in adult adoptees, and then conceptualize adoption as a primary trauma. It's that third objective that's the most important to me. And I will point out too, I was talking with Tamara before we got on, I have some research in here mainly because I have to, in a sense, and it's not that it's not important, it's very important. But the reason that I wanted to share on this particular topic, even though it would be a very much a niche topic in the field, is because I don't want these folks to go misunderstood and missed anymore, because they've spent the majority of their lives being misunderstood and missed. I want to get away from some of the assumptions that I made early on by educating folks and what to look for and what not to look for. Case in point, I did not necessarily conceptualize adoption as a trauma. The sort of the narrative is, at least the Western narrative, is that it can be a fairy tale, and that, the individual who was adopted somehow is the most fortunate person in the world. And that's just often not the case. Sometimes this is referred to as a trauma of relinquishment. And that phrase in and of itself, particularly that word relinquishment, got me, because of the nature of what the word means. you know, just the idea of giving something up that belongs to you. And then, you know, what a lot of adoptees, especially ones from birth or early in childhood, will tell you is that, you know, there's an issue with the fact that nobody ever asked them what they wanted. And so through the course of their lives, especially the course of the eating disorder, I think one of the metaphorical uses of the eating disorder is to function as a voice for these folks and to say, you know, you really didn't get my opinion early on, but I need to give you my opinion now. But because there's so much performance orientation, people pleasing, that message is often not being able to get delivered directly. So a couple little phrases that I am struck by, sort of like 12-step phrases. Like I like a lot of 12-step lingo. You know, like you know, keep coming back. Because it works if you work it and you're worth it, right? Like I really like that one. I like the idea that you, according to the 12-step model, you have to give something away to keep it. You know, those are really important things. There's a few of those phrases in adoptee culture. One of them is just this very simple short phrase that says that adoptees are adaptees. I want to stress that real quick. Adoptees are adaptees. So you may say, well, what is it that they are adapting to? Which brings me to another phrase that I really like in the adoptee world, which is, you know, coping in a sense for adoptees is trying to act normal in an abnormal situation. Or in other words, living for adoptees is trying to act normal in an abnormal situation. This is where you might see the relevance of an eating disorder as a coping strategy for individuals, for adopted individuals with eating disorders. You know, I often reference an older, research articles I have not put in here because it's not particularly relevant, but it goes all the way back to the 90s. I think it's by Cristiano and Mizes, M-I-Z-E-S. I believe they're out of West Virginia. And they look, basically this article is about coping styles and eating disorders. And it's the first time I heard the phrase emotion-focused avoidance-based coping. The idea being that because individuals with eating disorders, I think this very much applies to individuals with adopted individuals with eating disorders, is that they have issues with primary and secondary appraisal. Primary appraisal being the ability to correctly identify what the core issue is in any situation. Secondary appraisal is the ability to correctly identify the coping strategy to effectively address the issue. But since most struggle with the ability to correctly identify what the core issue is, they struggle all the more with the ability to identify a strategy that works. Therefore, the coping style, which is, you know, is evidenced by, in my opinion, any eating disorder behavior, is the attempt to make uncomfortable, unwanted emotion go away as quickly as possible by using any number of avoidance-based tactics that are present in the person's life. So again, adoptees are adaptees, and their coping skills, use of the eating disorder to deal with what is often experienced as the trauma of being relinquished, are the person with the eating disorder's attempts to make sense of life, to kind of create normalcy where it doesn't exist for them. So this is some information from the Center for Treatment of Anxiety and Mood Disorders. This may or may not have something to do with the first 3 questions on the post-test. I was told I could say that. So what problems do adult adoptees suffer from? Grief and loss and grief. I find that, you know, I've been in the field now about 21, 22 years. And I find the further I get into the field, the more time I spend talking about grief and loss in any situation, to be honest with you. Because, you know, life is constant change bringing nearly perpetual loss in some way, shape, or form. Some of it, of course, very minor, others very major. But the piece of the grief and loss process that I think most often gets sort of underplayed or missed, particularly in adoptee world, has to do with that anger phase of the process. You know, as I've spent time talking with more and more adopted individuals with eating disorders over the past couple years, I either find higher levels of depression than the typical eating disorder person would have, or I find higher levels of externalized anger. The depression thing for me, provided it's not biochemical in nature, I always look at the old school definition of the idea that depression is internalized anger. And I think that's very relevant, very prevalent in this culture, because there is such, or there can be such a pervasive fear of being rejected again, being relinquished again, that the individual with the eating disorder, the individual who's adopted, would have little to no desire to express any sort of anger to their caregivers at all, because someone in their life has already, in a sense, handed them off to someone else. So I believe what happens here is that as the eating disorder increases in the person's life, a large part of it is designed to be an expression of anger. Particularly, you know, I think through purging, this is my opinion, through purging behaviors, that I think anger is expressed. Through binge eating behaviors, I think anger is expressed. It's not that it can't be expressed through anorexia nervosa, but the restricting, yes, I just see there's more of a glaring expression of anger through purging and binging. So another thing I see kind of, I see this related to identity development a bit. And this reminds me of, you know, what we would formerly have called Asperger's syndrome. I see some of these folks very watchful in a group setting, and oftentimes they have a tendency to copy what it is that their peers are saying in group. Now they'll summarize it, they'll repackage it, but it's, from as far as the theme is concerned, it's the exact same thing. And it reminded me of someone who appears as if they are socially skillful when in reality they are not. So in other words, it's mimicking, copying. They learn very quickly to understand what the environment expects from them, and they go about you know, displaying that behavior even though it doesn't have any real roots. So there can be issues with self-esteem, self-confidence, increased substance use, increased rates of various mental health issues, which we'll get into in future slides. But the main part here is, and I believe this is on the post-test, is this issue of increased rates of PTSD. Along those lines, there's also significantly increased rates of suicide attempts and completed suicidality. So we know eating disorders are already as you know, deadly as they already are, but when you put it in this population, I think the statistics even go higher, which is a good transition over to the psychological effects of adoption. So maybe just being mindful of the time. So loss we talked about already. I wanted to chime in on rejection here, because it's not just a single case of rejection. I actually use the phrase primary and secondary rejection, and then there could either be further levels of that. At some point in the adult adoptee life's or adult adoptee's life, especially if they're in therapy, there's probably going to be some discussion about whether or not they want to find their birth parents. And there's a really interesting book I've been introduced to recently about an adopted person wrote a book about losing their keys, the keys being a metaphor for their biological parents, and how life for them is this attempt to find their keys. So I very much recommend that book. It's very interesting. And actually, the first time I read it, it got to me, kind of like it's getting to me now, from a standpoint of bringing up just a tremendous sense of sadness and loss about, we all, like most of us have lost our car keys or house keys at some point in time, right? And we know how frantic we can get of trying to find those things. But imagine that the set of keys you lost is your entrance into life. And you come to learn at some point in time that those keys might actually still exist in your life somewhere, but you have no idea where. You also don't necessarily know if those keys want to be found. And so there's this tremendous amount of vulnerability and risk associated with this rejection process. And I want to be very clear to not attribute these thoughts and feelings to every single person who's ever been adopted, right? That would just be silly. But we do need to pay attention to determine how the adopted individual feels about being relinquished. Did they see that as primary rejection? Are they concerned about secondary rejection if they were to pursue understanding or knowing their biological parents, possibly finding out they have siblings or a much greater family system that they were ever aware of? And then will those individuals accept them, right? Or are there just more opportunities to be rejected by people who really want nothing to do with the individual? So the emotional stakes are very high, to say the least. And I believe the rejection is probably something to do with question number 2 on the post test. Just like question number 3 has the, basically the idea is there's a strong likelihood that the person is going to find an increased sibling set is the correct answer. That's answer D, and that's false, actually. I mean, there's not a necessary likelihood of that at all. They may find a sibling set, they may not. They may also find that there's a sibling set that wants nothing to do with them, or perhaps there's a sibling set in which some siblings want to pull them back in the family, but others don't. And then how do you navigate that? There's a mixed message of being accepted and yet still rejected simultaneously. I would like to point out too that adolescence, and this is probably not going to be a surprise, but I still think there's some wisdom here. Adolescence is a time where we know eating disorders are activated in the general population. Same thing can be said for the adopted population. And it makes sense because as they get older, they're having a better understanding of what being adopted actually means. There's more of a shift towards individuation. And then, of course, there's increased focus on the psychosocial development of a person's identity. Common risks in this area include more rejection, increased prolonged pain, especially if you set out to find your biological parents, find them, and then have to make a determination of whether or not you're going to send a letter, because that's the typical approach to this process, is sending a sort of a non-threatening, invitational-based letter to gauge any interest that the biological parents might have. And then there's this other risk that has to do with finding out that there might be a negative adoption story. So imagine you're adopted. Imagine you've been told your whole life that your adoption was a blessing and that you're a gift, and it was in everybody's best interest for your biological mother or father to let you go, only to find out that none of that was true. You can think of all of this negative scenarios in which a person might be given up for adoption. So if you've already got a narrative that says that you're bad or that you lack worth because someone gave you away, there's a risk of that narrative almost being reinforced and doubled down upon if you find out that the adoption story is actually worse than you imagined it to be. Which brings me to my final point for this slide. I want to kind of go back to DBT a little bit. In one of the dialectical dilemmas in DBT is referred to as unrelenting crisis versus inhibited grieving. And I think this very much speaks to that concept of increased and prolonged emotional pain in the lives of individuals, of adoptees with eating disorders, and what is the function of the eating disorder at that point. So I think the eating disorder, the behaviors associated with it, the focus on the body are an attempt to disconnect from or numb out as much as possible the emotional pain that this person often deals with on a regular basis when they look around the family and are reminded that, yes, I am with these people, but these people are not my keys. This isn't where I came from. I don't quite fit in. And depending upon how a person fuses or defuses from that particular message is going to determine how much or how intense their emotional pain is over time. So I think I want to move on just to make sure we keep things going smoothly and start to look at another study here. This is, you can see what the title is there. The key points of behavioral issues are primarily associated with emotional, environmentally less than optimal conditions of life before adoption, longer time spent in orphanage, age of removal from biological family, and age of adoption. There were 4% of the study here of eating disorders were boys, and there was no change over time. But 16% of eating disorders in girls actually increased to 20% over time. I'm going to encourage you to read these articles. Like I said before, I don't want to present numbers. I want to talk about story. But questions 7 through 10 would be associated with this particular study. And I kind of want to look at that really quickly. The authors here are big on what they call pre-adoptive and post-adoptive education. And I think we do a better job at this now, but historically, I've seen adoptive parents will bring this, or adult adoptees will bring the pamphlet that the only piece of literature that they were given early on in their adoption process, which is just, bifold little piece of paper that says pretty much nothing on it at all. And so I would add that not only do we need pre-adoptive and post-adoptive, but it really should be ongoing. And what I mean by that is like a lifetime of involvement of support as needed. This is a side note here, but I'm starting to, and I've been talking about this a lot lately with my eating disorder group. So I run an IOP, PHP here out of Phoenix and Scottsdale. Moving away from the language of recovered in a sense, although I do believe people can be recovered, but I also believe that recovery needs to become a lifestyle. And not just for individuals with eating disorders, or not just for individuals who are adopted. I think for people in general, our mental health needs to be something that is consistently attended to, like we would attend to a garden or something of that nature. So authors here are focusing on pre and post education. Interesting concepts in here with adopted individuals in this study. 6 months after their adoption, their behavioral issues, whatever they were, eating disorder behaviors included, began to decrease. However, at 12 months after adoption, they started to display new behaviors, eating disorder behaviors included. So, the thought occurs to me, okay, so why would that be the case? And again, I do not pretend to be an adoption expert. I'm diving in as quickly as I possibly can. But my guess is there's probably something to do with the idea of being newly adopted would be similar to almost being in a long-term dissociative episode. In which it's going to take you in your central nervous system extremely long time to figure out what just happened to me. And it might be, depending upon the age, the person is either just strictly in survival mode, or they're learning the game, what ACT might call adaptive peak approach to survival. But it may also be the case that at the 12-month mark, once that system of self-protection has calmed down a little bit, I could see where they would start to feel their feels a little bit more and then have to pull on some sort of coping strategy, at which point eating disorder behaviors seem to present themselves. And what's interesting, if you look at question 10, what types of eating disorder behaviors have a tendency to present themselves in this study are the chewing, swallowing, regurgitation, and rumination type things. So and of course, when I hear those terms, I think reactive attachment disorder, I also think ARFIDs to a degree. So just want to point, just to kind of summarize this, you know, and this is something that's going to come up in another study as well, is that individuals who are adopted have a tendency to display a higher range or higher prevalence of various psychological and psychiatric issues. Okay, moving forward. I'm operating multiple laptops and desktops at the same time to make sure I get everything in, so bear with me a little bit. In this particular study, in the International Journal of Eating Disorders, they look at 3 waves. This is a very interesting study as well. And this has to do with question 6 on the post-test. Basically, the idea that I want to focus on is the contact with the biological parents was related to increased eating disorder diagnosis. Now, there's a lot more work and discussion that needs to be done on this, but I'm looking at this from the standpoint of that reopening the rejection wound again, and how it must feel to be in the presence of someone who, for whatever reason, chose to give you or give that individual person away. I should clarify, I'm not adopted myself, but some of the stories of adoption I've heard in the past 2 years from individuals who are in my eating disorder program were very eye-opening to me. There's a particular 20-something young lady I was working with from, we'll say, an Asian country, who has, let's just say, a developmental delay. And you know, I'm sharing this because I want you to understand where her core beliefs come from. Her core belief is that she is worthless and never will have any value, largely because of the thing that makes her different. So in the orphanage that she stayed in for a few years, when prospective adoptive parents would come, the staff at this particular orphanage would hide this girl because they didn't want her to give a bad impression of the facility, nor did they want her to interfere with healthier kids being adopted. Now, you might say, well, how does she know that? The reason she knows that is because that's what they told her. So this wasn't a situation in which she made an assumption. She understood that she was being told that because you're different, you're bad. And, you know, and she's very much anorexic. And I fully believe that has everything to do with the fact that she's trying to manage the most intense emotional pain of rejection a person could ever experience, perhaps, of literally being hidden. I mean, when she processes this level of trauma, she can barely breathe and at times barely talk. Is she doing better now? Absolutely. And I'm not 100% sure. I know I'm talking about biological parent here, and I don't know how I got onto that particular story in this situation. But I think going back to the biological parent, the idea is this. Some of the healthiest adopted folks with eating disorders I've ever worked with who've done tremendous work get to this phase in their treatment process where they know who their biological parents are. They know how to contact them. They know that they need to start writing a letter, but they will spend months and months and months deliberating whether or not it's worth it. And I'm going to get into some of the core beliefs about that in a couple screens from now. So I want to move on. Here we go. So this one, this is another Swedish population study. I mean, thank God for that country and all the work that they do on studying folks. And you're going to look at questions 4 and 5 here on the test. There's 2 things that stand out to me here. Like the overall key point is there's a higher prevalence of psychiatric issues in adoptees over non-adoptees. But what stood out to me is that it actually seems like major depression is more prevalent than anorexia or other eating disorders. But that the overall difference, if you look at male and female adoptees in this study versus male and female non-adoptees in this study, there's actually a greater prevalence of other specified eating disorders than anorexia itself. And I think there's a number of ways to look at that. I look at this from the idea that a person's relationship with food oftentimes mimics what they have or don't have in their actual relationships in life. So when you have an individual who's binge eating or just emotionally eating or something to that effect, I see that as sort of this like more relational based drive for connection and connectedness. Whereas in my mind, anorexia doesn't really create that. It creates more aloofness and more isolation. So that's my first sort of guesstimate of why this would be the case. But I want to move past this stuff. I know we didn't spend a lot of time on these articles. I didn't want to, but you have the references somewhere. Now I want to get into the good stuff. I learned early on in my eating disorder training, this would have been probably 2001, 2002, about what I was told were called the 3 Ps of eating disorder treatment: the perfectionism, the performance orientation, and people pleasing. And I now understand these to be more of boundary issues, depending upon which sort of model you look at these from. But I want to show you what they look like in a particular individual that I work with. And I love some of these slides, by the way. I was really, really intrigued by this particular PowerPoint, the visuals. So perfectionism. So this is an individual I was talking about before who's done a lot of work and is just moving towards recovery and acting recovery like on a consistent basis. She has identified her biological parents, knows where they live, and is stuck, like most people, on whether or not to write this introductory letter. But when we talk together about what prevents you from moving forward, this is an exact quote. I want to be perfect before I present myself to them. Now, there's 2 things that stand out to me there, is that is the thought process that goes all the way back into early childhood and adolescence for this individual. And she's been in therapy for probably 30 some odd years, realizes that there is no validity or real truth to that comment, understands that perfectionism is almost a psychotic process according to some models. And yet she is trying to figure out, how do I polish myself up? How do I get the tarnish out of my reflection so when these people see me, I make sure that they don't tell me to go away? Or how do I make sure that when they read my letter that I've presented myself in such a way that they don't see me as flawed or broken, but want to meet me and give me a second chance? So here we see this classic example of what I was talking about before, these high risk factors of primary versus secondary rejection. I'm really looking forward to, by the way, the questions that are going to come after this and some of the comments as well, because this was a game changer for me, and I hope it can be that for you as well. Next slide. looking at performance orientation. What did this look like? This looked like being the most compliant, driven, achievement-oriented kid who went out of her way to be better than her biological siblings, because after all, core belief here, I don't trust anyone will stay because my mom gave me away. So this person, what she determined early on is that if I can, in a sense, create a stage for myself and shine a spotlight on my behaviors, I can make myself less of a burden to my biological family. I can make them very proud of me, but most of all, I can make myself useful. And if I'm able to make myself useful, then it significantly decreases the chances that someone will give me away again. And yet all of that is fueled by this fear of rejection. And that at some point, think about this, here's another dynamic here too, is that not only do I want to put my best foot forward, right, but I'm also going to hide my emotional pain. And I'm also not going to talk about the trauma that occurred to me because I don't want to become a burden or a nuisance to this family. So whenever anyone asks me if I'm okay, of course I'm okay. I'm great. I'm blessed. I'm a gift. This is the greatest thing that ever happened to me. Meanwhile, I'm not going to talk about being molested as a child by the babysitter. I'm not going to talk about, this bad thing that happened at the hands of a cousin or an uncle. I just can't take a risk. So the performance orientation is often layered on top of secrets. People pleasing. This particular quote got to me as well because it kind of caught me off guard. The individual was talking in a group setting, and the group, just so you know, the group itself, although at times there were 3 adoptees in the group, right now there's only 1, but the therapeutic group has been so phenomenal in coming to understand how traumatic it was for this individual to have been given up for adoption, and how much anxiety she's dealing with right now, thinking about trying to reconnect with biological parents. But she was processing something, and then all of a sudden she said, yeah, and this is messed up because there's sadness when a baby was born and that baby was me. And she went on to talk about, like, there was no, and she knows for a fact, like, there was no baby shower and there was no celebration. There were only contracts and secret conversations to make sure that people's identities were protected, and the story never got out because no one wanted to deal with the shame and from the era of when this happened. And so again, think about core beliefs and this idea of that, it's pretty common that when we find out we're pregnant, we're going to have a kid, that there's some excitement here. Her thought process was, when my mom found out that I was going to be born, she was sad. And that's, as much work as this person has done, it's still extremely difficult for her to get past that. Okay. I want to explore in this next some phraseology that the person uses to talk about themselves. I hear this with various adopted individuals I've worked with over time. And I'm just going to ask, as I'm going through this, now would be a good time to start sending in some good questions and comments. So these are names that other people have called adopted folks that I've worked with, or that adopted folks call themselves, in no particular order. Oftentimes the adoptive person will refer to themselves as a secret. And, so we may say, well, what type of a secret? Well, it's a secret that the biological parent might keep. It might be the only person in the world that knows that this child even exists, or one of very few people, right? Or perhaps the adopted family has kept it a secret because the parents didn't want anyone to know that they were not capable of having biological children. But this will often, as these kids and now adults have described it to me, the secret plays itself out as often being extremely shy around new people, not wanting to draw attention to themselves, so often hiding or standing behind their parents or standing behind biological siblings, to sort of, in a sense, model their place in the family as the person who really shouldn't be there, in a sense. The next phrase is the experiment. The experiment. This is the message that comes with the individual who's extremely concerned that if they do not perform well enough, they'll be given back. And you might see this represent itself in the form of a child or adolescent who keeps a separate suitcase or a backpack full of clothes tucked away somewhere. Because their belief is that if they mess up enough, or they mess up one too many times, the experiment is over. We gave it a shot. This person is a foreigner or an outsider to our family. They're a commodity, or they feel like a commodity, and therefore if the commodity doesn't do what it's supposed to do, then it is returned to the shop where the commodity was purchased. And this is reminding me of something too, as far as the foster situation. I had the opportunity, in addition to having 3 adoptive folks in the program at the same time last year, I also had an individual who had grown up in the foster system. And I had heard stories about individuals in the foster system with eating disorders before, but they were sort of fewer and farther between. But what this person said reminded me of something along this line of being an experiment, or not, just not really fitting anywhere, in a sense, is that when kids in the foster system do what is called aging out, so they turn 18, the routine is that their belongings are placed in a large duffel bag, or in many cases, a black trash bag. They're given a certain amount of money. They're released from the home that they're staying in, and they're on their own. I see a lot of parallels in their behaviors and the way that they relate to their eating disorder as similar to the adopted person relating to their eating disorder. Again, the sense is that there's no permanence there, that my life is subject to change at any moment, and that I'm not the one who's actually in control of that process. It's the individuals who are actually doing the experiment in my life. Now, the blessing. The blessing and the secret often interact side by side, in that outwardly, for some families, the adopted child is consistently spoken of as the blessing to certain individuals, but to other individuals is kept a secret. Obviously the biological parents, the adoptive parents are the ones who are making that decision, but the child in both ways, or even the adult, has come to understand that, to certain people in certain situations, we don't want anybody to know about you. In other situations, we're going to tell people that you're the best thing that ever happened to us. But when you tell a child or an adolescent even into adulthood, that they are a blessing, or in a sense, a savior for a family that couldn't have children, that puts tremendous pressure on them to toe the line and live up to that process. So when you have that much stress, once again, how's a person going to cope with something that's so unrealistic? You know, and food, eating disorder behaviors, of course, are easy. Look at that. So, or excuse me, easy answer to that dilemma, especially if perchance you are adopted into a family that has its own weight and body issues or dietary restrictions, which is often the case. You know, it's interesting to see how an adopted child, in a sense, learns how to have an eating disorder from an adoptive parent who has his or her own eating disorder. Very much related to the blessing is a gift. And, you know, the idea here is that you're special. Matter of fact, you're extremely special. You're the most special thing you could ever possibly have happened to us. And we're going to dote on you and make sure you feel that way as much as you possibly can. The idea, but then the problem is when, as the child gets older and starts to understand, again, the adolescent gets older, the adult starts to understand the adoption process more than they ever have, they still have to reconcile how it is that they are a gift for someone that, and while someone else didn't want them in their lives. And so I'm stressing that again, and I'll kind of keep coming to that in different ways, shape, or form, but that's because I want you to walk away and really consider, is the trauma of adoption, a trauma of relinquishment, actual trauma, actual PTSD? I'm convinced of it at this point. I don't question it at all. And it makes it something that I look for on a regular basis. You know, just one little thing, I actually added this to my psychosocial template because I had never put it on there before, to ask a person about whether or not they are a foster or have been adopted. And I mean, just that simple act of adding that to the assessment is validating for these folks. I'll tell you my plan at the end. Here, let me go through this last one. Not the real one. Not the real one. This is a message that comes oftentimes from adopted kids who have siblings who are biological to the adopted parents, or to, you know, adult friends of adopted parents who really just don't have any common sense. But the adoptive child is considered not the real one. They're the fake kid because they're not the biological kid. And so when you imagine, like, you know, again, even into adulthood, and the reason I refer to, you know, often these starting in childhood, moving into adolescence and adulthood, is because that's when people are most likely going to be adopted. But also understand that, I mean, these developmental delays are taking place all through life. We very much could have a 45-year-old that still acts like a 6-year-old or a 10-year-old, when is the first time they refer to as the, oh, well, you're not the real kid. I was looking for your sister or your brother, or something like that. Or siblings who consistently identify, biological children who consistently identify their adopted siblings as the adopted one, as the real one, or as the not real one, as the fake one, or she's not a part of the family. We got her at a hospital. You know, all these different terminologies or languages that are used to basically suggest that the adopted person is in a one-down position. So, moving towards, you know, transitioning into question and answer and wrapping this up, because I know you guys have things to do today, and I want to make sure that I don't interfere with your day. My intention at this point is to, and I've already kind of begun the very basic foundation for this. I'm going to be want to create a program that is specific to adoptees, not just those with eating disorders, but those with substance abuse issues and any number of mental health issues, because we've established that major depressive disorder, anxiety disorder, PTSD, OCD, eating disorders, and anything else you can name that would be a level 1 or axis 1 diagnosis are all going to be prevalent at higher rates in adopted individuals. I believe, however, that there would be extreme benefit to having a group of adopted folks that already know when they walk in the door, someone is going to understand them to a level that they've never been understood before, or most likely have never been understood before in life. I do believe it's necessary. I don't think it's going to be a huge program. I don't think there's going to be 20 people. It's either being 10 or 12, but I do believe that the need is out there. As I said in the very beginning, I see the adopted community as a culture, subculture, that has a specific language, has specific rules and traditions that we need to be sensitive to. And also, I want to stress to keep in mind that, you know, assumptions are made on a regular basis that a person who's been adopted likes the fact that they've been adopted and is somehow overly blessed in life. And I would suggest that that is often not the case, and that individuals who hear those messages become extremely angry, among other uncomfortable emotions. So, Tamara, I think probably a good time to come back to you.
Great. Thank you, Sam. That's just fascinating information. And boy, howdy, do we have some questions. So that's good.
Okay.
Before, as you're handing things back over to me, one of the questions that was multiple was, what's the book title that you mentioned, that using keys as a metaphor? Will you reiterate what that book is?
I will. Yeah. And then get out of this. That book is called The Keys Book. Just Keys Book. And then it's by Ruth Monig, M-O-N-N-I-G. The Keys Book by Ruth Monig.
Perfect. Thank you. It's okay. Don't worry about sending it back to me because I can do it without. Let me just do a couple of quick reminders because I know some folks need to bail out at the top of the hour. So I'll tell you a couple of reminders about the post-test. Then if you need to go, we certainly understand. And if you want to hang on, we'll address a few questions after. So just a reminder that when I end the webinar, that an evaluation will automatically pop up on your screen. If you would take just a minute to complete that evaluation, that would be really helpful for us. That's a continuing education requirement for us. It's completely anonymous, so please feel free to be candid in your feedback. And if you'll fill out that information, then we tabulate those results and send them to the CE entities. And then lastly, about an hour after the webinar ends, then the post-test will come to you in a separate email from GoToWebinar. There's a link in that email to take the online test. You must pass the test online in order to receive continuing education credit. And once you take the test and pass it, then your CE certificate will automatically be downloaded to your computer. So if you don't see it on your screen, sometimes it goes to your downloads file. So take a look there. All right, Sam, here we go.
All right.
Here's a question. This is from Melissa S. Since rejection and loss are such huge themes with individuals who were adopted, how do you balance sending a client to a higher level of care, especially residential, without demonstrating rejection? Great question. Good luck with that one, Sam.
Yeah. So we're out of time. It was a great question. No, that really is good. Like that's so insightful to understand that process, because you're right. We're going to run into that. I've run into that several times. So and the way I do it is I'm a small step, long play guy, right? So if I know in 2 or 3 months I probably need to have this person in residential treatment, I'm going to start chipping away at it about 3 months ahead of time. And they're going to be really like these little micro thought processes, just enough to plant the seed while consistently reinforcing what's the purpose of going away. But it is tricky nonetheless. So you have to give it plenty of time. You can't just drop it on the person, but also realize that they're still probably going to be processing it when they're even in residential treatment. And I don't think there's any way to avoid that.
Great, thank you. You referenced this, there was a question from Connie T. You referenced a Swedish study, and specifically, she says the difference in the prevalence of eating disorders between male and female adoptees. She's just interested in knowing more about the study, if the study addressed any differences between males and females by race or culture, or if you can tell her where to find more information about that study.
I can tell you where to find more information about the study. I don't.
Perfect.
The answer off the top of my head is I don't think so, but we'll get you that info.
Great, thank you.
Yeah.
Okay. Tristan M says, let me get there. There we go. I work with foster parents, and one thing that is commonly noted is food hoarding. Seems like the more parents try to control these actions versus trying to understand why and have compassion, the parents actually exacerbate these behaviors. Seems like it could lead to an eating disorder. Your experience regarding this?
Yeah, 100%. My question is, have they already started locking the cupboards yet? And then limiting the food that actually comes into the house, because none of that's going to work. Even if you freeze all the food, those kids are still going to start eating the frozen food. So I have had direct experience with that. It takes a ton of education and buy-in on the part of these foster parents to get them to change their behaviors. I see it associated with reactive attachment disorder, without a doubt. And yeah, it's counterintuitive. So the measures that the foster parents generally going to take, not going to be effective. They are going to make matters worse, for sure.
Thank you. This is from Emily G. Do you have any experience working with adopted individuals who were pregnant with their first child during treatment? Can pregnancy trigger eating disorder behaviors?
So the answer to the first question is no. The answer to the second question is yes, for sure. Wait a second. Now, I think I just remembered, I remembered something that might actually fit the answer to number one. I'm not sure about that, but I'll have to go back and check on that. Now I'm curious. But for number two, yeah, pregnancy, I mean, we'd have to spend an hour talking about all the ways that that could happen, but I'd love to talk to you about it in person if you're interested. I mean, my contact information is available, so give me a holler.
Thank you. Hold on. Next question. Do these issues apply to when the person is adopted by a step parent?
Ooh.
Yeah, that's a good one.
Yeah, another awesome question. Yes, I don't see there's any, now obviously there's a difference, right? You can see where the step parent adopting a child is different. And I think a lot of times it can be received in a much better positive way than adoption by a non-step parent. But I don't think it changes the core beliefs automatically. That core belief of someone didn't want me it's one of the hardest core beliefs I've ever run into. That the idea of like, it's so hard to help people understand that they're worthy when they've never understood that to begin with. And then when you throw in the adoption thing and you still try to help them understand how valuable they are, they always have this, yeah, but somebody gave me away trump card that's almost equally impossible to address. So I think it is different. I think it could be received better than the typical adoption, but I don't think the core beliefs go away.
Thank you. We have lots of folks who just expressed appreciation for the webinar and what a great job you did. And we have some folks who indicated already that they're reaching out to you directly with your contact information. So I just want to end with this last one. It says, this is from Rebecca B. She says, I am an adult adoptee with an RD who specializes in eating disorders. And I just want to say you did a wonderful job speaking respectfully about the adoptee experience, even though you are not an adoptee yourself. Thank you. Wonderful.
That's awesome. That's so good.
It is great. And there were several folks who expressed similar sentiments and are reaching out to you directly. So I just want to say again, my thanks to you, Sam. Sam and I go back a ways, and it's wonderful to be able to have my friends be able to be presenters in our webinar series and Sam is just one of those way at the top of the list. So I'm so appreciative of you, Sam, and you taking the time to do this for us today. And I'll let everybody go so that you can take the evaluation and get your online test in about an hour. Our next webinar is Wednesday, July 14th, again at noon Mountain Time, and that one's on co-occurring type 1 diabetes and eating disorders. So we're looking forward to that one as well. Thanks again, everybody, for taking the time today. We hope to see you next month, and in the meantime, be well. Bye-bye.
Bye. Thanks, everybody.